Hi, this is Abbey from Texas Retina Associates in Dallas, Texas. I'm here at Retina World Congress where I've presented on a clinical trial update for EYP-1901 for retinal exudative diseases. So the interesting thing about the bioerodible design of EYP-1901 is that you've got in the background after the injection a sustained release of a tyrosine kinase inhibitor over the course of roughly 6 to 9 months. So you can kind of have some comfort in knowing that during that time frame, you have active disease control going on while you consider possibly also adding on these bolus injections of anti-VEGF. And so for me, the way that I look at it, if things work out as planned, is that we would have this as a therapy early on in the treatment of a patient with, say, wet AMD or DME, and then I continue to supplement my patient with an anti-VEGF and try to extend the patients out as long as possible with a combination of those two medications. I think you've got a good supplement on the side of a multifactorial treatment with TKIs in that you're suppressing VEGF receptors, you're suppressing PDGF receptors, but you're also suppressing inflammation through the JAK1 pathway with IL-6. So having all those things together, in addition to bolusing anti-VEGF, can give us a multiple treatment modality that can probably get us our most durable and effective outcomes for our patients. The two phase 2 trials that have been discussed so far, one for wet AMD and one for DME, there's the DAVIO2 trial for wet AMD. That trial included previously treated wet AMD patients who essentially were either given a low dose or a high dose of EYP-1901 after 3 bolus injections of aflibercept, or they were compared to patients who received aflibercept alone every other month. And the interesting thing about that was that when the patients were followed after getting EYP-1901, when they looked at them every month with certain pre-specified retreatment criteria, there was a very substantial reduction in treatment burden in those patients in terms of the patients who got retreatments throughout the year of the trial. It was roughly over 80% reduction in treatment burden when they compared it to the pre-trial coming in of how many treatments they received in the previous year. So these were actually very high treatment burden patients when they came into the trial. On average, they got almost 10 injections in the previous year. And so many of them went from 10 injections to no injections after receiving EYP-1901. Now, it was roughly 2/3 of the patients in the trial who got no injections or were supplemental injection free over the course of the year. But I think in the real world, in terms of wet AMD, it's going to be an interesting question as to how much fluid we want to tolerate when we have this drug in the eye. Because when in these clinical trials, the parameters for dosing are not exactly the way we would do it in the real world, I would say. And so I think it's going to be it's a more nuanced thought and question about when we're going to be treating these patients if EYP-1901 is already still working in the eye. Maybe it'll be a question of intraretinal fluid versus subretinal fluid. I think for me, I would be more aggressive with anti-VEGF if I still had intraretinal fluid, and maybe I'd be able to tolerate some subretinal fluid in these patients. But I think we'll learn a lot more with the phase 3 data comes out for that. On the flip side, when we're thinking about diabetic macular edema, we are informed a little bit by the phase 2 trial, the VERONA trial. And in that trial, the patients were actually previously treated DME patients and were randomized to receive either low dose or high dose EYP-1901 with an aflibercept injection on the same day at day 1, or they received standard of care with one aflibercept injection at day 1. And then the patients were followed monthly after that, and they could be retreated based upon vision and anatomy considerations for retreatment criteria. And so in that trial, what we noticed was the primary endpoint was met in the sense that the time to a first supplemental injection was extended in the EYP-1901 group. And so we see and saw in those patients as well that roughly about 73% of the patients in the EYP-1901 group were supplemental injection free at the end of the trial compared to just 50% in the aflibercept treated group. So we do see, again, a reduction in treatment burden there with those patients. But again, how much fluid can we tolerate? How much edema are we willing to tolerate? That's going to be something that will be answered with the phase 3 trials that are currently being enrolled. But also, I think the real world use will give us a lot more information about that as well. The good news so far is that we have data for about 190 patients who have received the vorolanib intravitreal insert or EYP-1901. We have not seen any drug-related ocular or systemic SAEs to date from those patients. We also have not seen any cases of anterior chamber migration of the implant. We haven't seen any reports of anterior chamber opacities at all, and we have no reports of occlusive vasculitis as well. So overall, the picture for safety so far has been quite good. So that's really encouraging for our future use of the drug. I think the fact that we may be able to do fewer injections with this drug is going to reduce our risk of endophthalmitis overall, and I think that's going to be a major win for us as clinicians and for our patients as well. For me, I think in the wet AMD space, these are going to be the patients who, not the absolute worst of the worst patients, because I don't think it's necessarily going to be perfect for those patients. I think it's going to be mostly the patients who I can control very well, but I can't get them past, say, a 6 to 8 week dosing. Those patients, I would love to see if I can have the insert in their eye and see if I can extend them at least to maybe 3 or 4 months for their dosing, or maybe longer than that. Those are the patients who I think would really benefit from this, just reducing their treatment burden by a decent amount more, extending their interval for treatment with their anti-VEGFs a little bit more would be really beneficial. But I don't necessarily think this is going to be a drug to treat the worst of the worst patients who have, polypoidal vasculopathy and things like that. I think it's more so going to be for the patients I can't extend but are actually under control with frequent injections. The most exciting signal for me so far is just how few injections are necessary for the patients who are getting this right now. So, I mean, I think there's going to be a lot more to be learned about whether the multiple mechanisms of action can provide even better efficacy up front for patients. But I think we need to learn more about that before we can state that being the case. But we already can see, based upon the data that we've seen, that there is a substantial reduction in treatment burden. And that's already a huge win. I mean, we are already having, we're being overwhelmed by patients in our clinic who need injections regularly. And so any little thing that'll allow us to reduce the burden on our staff, on our patients, on the physicians themselves, I think is going to be a major win for the retina community.